I talk with a lot of hand-cranking. Someone might talk of any more to say.
All right, thank you very much.
Thank you very much. I appreciate it, and I hope the world lasts for you. Have a good day.
Yeah, so what's going on here is that, you know, we're used to seeing Brokaw's aphasia or expressive aphasia, where their speech is more telegraphic. I have a hard time getting the words out kind of a thing. This is called a fluent aphasia, or sometimes Wernicke's aphasia. So the expressive aphasia or Brokaw's is more frontal here, right next to the motor strip. And so you're going to have a right hemiparesis with it, or facial droop, or something that tells you that it's a stroke. And then you have this obvious expressive problem. If it's back here in Wernicke's area, you're away from where the motor area is, you may only have aphasia. That's why I call it isolated aphasia. That's the only stroke sign you have. And it's fluent, so they're speaking in full sentences. And you can tell, you know, he had a lot of paraphasic speech with funny words mixed in there and that sort of thing. But he had some full sentences, and I've seen patients with fluent aphasia like this, where they are speaking in full sentences and it's sort of making sense. So for example, I had a gentleman who was kind of angry with what was going on. He was scared, you know, and so I'd come up to him and I'd say, well, how are you? I'm fine, leave me alone. And then I'd say something else or ask him another question. He'd say, I'm fine, leave me alone. He had no idea what I was saying most of the time. But he had a sentence that he could say that sounded normal. And so I thought this was like just an angry man. You know, I had no idea. And eventually starting to ask questions like, hold up 2 fingers on your right hand. Or, you know, doing things where, you know, without visual cues, he would have to understand in order to follow that command. It became clear that he had a significant receptive aphasia. We call it a fluent aphasia because oftentimes it's like this guy. There's all kinds of speech there. They're not, you know, troubled to find speech. They can talk a lot, but it can be full of paraphasias like this, or it can be kind of almost normal sentence structure, but they're not understanding. You can't have a good conversation with them. Hugely disabling and isolating problem. And these are walking patients. You know, they come into the ER, you know, walking, you know, maybe not by ambulance, and get called delirium, or, you know, confusion for other reasons. And the problem with it is that delirium can look like this too. So, you know, it's a very difficult one to sort out into, thanks, and to make decisions. So you have to, you know, deal with the history, distinguishing from non-specific confusion and delirium. You need to do an exam. You might look at several right-sided findings, like on the left side, you're right near the visual radiation, so maybe they'll have a little bit of a field cup, maybe not, or maybe a hemisensory, but they're not going to have a hemiparesis if it's real way back here. So you look for those signs, and then if you don't have those signs, all you've got is this patient with confused language. You sometimes have to depend on imaging. I will sometimes in my hospital use perfusion imaging, but also even just the CTA to look for, you know, a branch middle cerebral artery occlusion can be helpful, or sometimes I'll take them to MRI. And then historically, in order to say, okay, is this delirium or is this a Wernicke's aphasia from stroke, sometimes you have to take the history in advance. So I think I had put a case in here that was just that. This was a patient with Alzheimer's disease who was just starting into her delirium with a little hallucinations, and then she ended up having this sudden onset of a language problem, and we figured out, no, this isn't stroke, it's really delirium. You know, she was kind of having specifics, familiar story or something.
We were just talking.
Yeah.
Like, that's the girl that's upstairs.
Yeah, we can have cases like that quite often, and I can tell you this is an area that I'm actively looking at because it's so hard not to treat cases like this that come in. We call it with, you know, a focal encephalopathy, where, you know, their dementia or whatever has set them into disordering their mind, and they look like a Wernicke's aphasia. On the other hand, you know, a lot of times we'll see this missed with people just thinking that it's confusion and nothing else, and it's really stroke. So it goes both ways in terms of the distinguishing things. So I guess what I'd say is, especially in the outpatient setting, when someone's coming into your ER, You'll see this more as delirium in the hospital, because hospitals make people delirious, as you probably know. But when patients are coming in cold from the outside, more often than not, this kind of picture ends up being a stroke rather than a delirium. So, another one, visual field defect. This is a 59-year-old gentleman, known atrial fibrillation, sudden onset of confusion while out in the car with his wife. He was actually driving and got stopped by the police for driving erratically, and it ran into a curb on the passenger side. So he seemed kind of confused, so they thought they'd take him to the emergency room. And when he got to the emergency room, he seemed a little disoriented, and he had a short-term memory loss. And his wife was swearing up and down, "This is really, not my husband. There's something wrong here." And CT was negative, and he was admitted for further evaluation, got a neurology consult. Neurologist goes up in front of him and says, "Okay, now we're going to do your cranial nerves. Which hand is moving? Which hand?" He's got a right visual field cut. Went right through the ER without that getting recognized. Why? Because people coming in with visual field cuts sometimes don't recognize it. And so they're not going to tell you. And again, they're walking and talking patients. They don't look like a stroke patient. So unless they tell you, or they might come in with something sort of non-specific saying, "My vision just isn't right, it's a little blurred," or something. And, the reason that I think this happens so often is that rather than with a migraine you get this visual light display in part of your visual field, they just shrink their visual field. So they just have a new visual field that's less. And sometimes it's hard for them to recognize that that's what's going on. Every once in a while I'll have someone come in and say, "Half of my vision is gone." I mean, it should look like, look, this is the stroke that our gentleman ended up having. He didn't get TPA treatment. He had arrived just in time for it, but he didn't get it because we missed it. Yeah, so sometimes I'll do a CT if I'm uncertain, but honestly, you could figure that out from the exam. So all it really takes, and this is one thing that we're going to be asking you to do in triage, when you're seeing someone with a new neurologic deficit, and you do your neuro check, and I don't know what you guys do, if it's Cincinnati or whatever it is, but what we're going to want you to add to it is a visual field check. Because you think about it, your vision comes back through the thalamus, and then the visual radiations go through the parietal and temporal lobes to get back to the occipital lobe. So if you check their visual fields, you got fully half of their brain you're checking. So very important sign of stroke, and missed because patients don't always recognize that we've got a problem. So, and you might ask, well, it's only an NIH stroke scale of 2 to have a visual field cut. How important is that? Are we going to be treating those really mild cases? And as from my discussion before about mild stroke, absolutely. And this isn't mild. This is hugely disabling for them. If they don't have half of their visual field, they might not drive again. They might have, if it's right down the middle cut, they might have difficulty tracking across a page to read. You can imagine this is life-changing for people. If it involves the temporal lobe, if they get that whole posterior cerebral artery territory, it involves the temporal lobe and the dominant hemisphere, like this gentleman, you're instantly demented too. So he really suffered from this one without treatment. Okay, this is my hardest one to, wrap my arms around it myself in the emergency room. And I think when I talk to ER docs about vertigo and dizziness, it's hard for them to think about calling codes on some of these patients. So I want you to know we're talking about spinning dizziness, vertigo, sense of motion, not lightheadedness. Okay, and we'll narrow it down to what we think is appropriate to call a code on. But like with aphasia, vertigo, and nystagmus, jiggly eye movements, might be all that you see on the exam, and it'll look very much like someone with labyrinthitis. So it can be very hard to tell the difference between a stroke and a really rip-roaring labyrinthitis. Here's an example case. Again, I'm kind of giving you missed cases so that we learn how not to miss them. 65, over the age of 65, risk factors of hypertension, hyperlipidemia, diabetes. She had nystagmus, but otherwise her exam was normal. She was treated for what was thought to be labyrinthitis and released, and then she returned a few days later with a visual field cut and an aphasia. So what happened to this lady? So she was having this stroke in the cerebellum when she came in initially. And then this, giving her the visual field cut and getting up into language area happened after that. So she had a clot sitting in her vertebral artery right here, taking out this vessel, the pica, that serves blood flow to the lower cerebellum. And that was the stroke that was happening initially. And then the clot migrated down here, landed in the posterior cerebral when she came back for her second stroke. And she was now, having much more of a significant problem. I mean, this was symptomatically bad enough, but this was, long-term disabling. So, what can happen if you have a stroke in this vascular distribution? One, this pica vessel, you can have a small little area in the medulla also get affected. It can extend to that area, and then you have a brainstem stroke, and you can't swallow, and you have a cadre of other symptoms. If you have a large area of the cerebellum involved, 2-3 days after your stroke, you can be dealing with hydrocephalus from compression of the fourth ventricle, and it's a surgical emergency, or compression of the brainstem, even worse. You can have, like Our Lady, artery-to-artery embolus up the basilar. We had a young woman who had a dissection of the vertebral artery, came in, got treated, kind of for a labyrinthitis sort of picture, came back to another hospital, and, she went to another hospital and came back to our hospital. Now she had a basilar artery thrombosis, and she was in a coma. So, not a small thing to miss. Now, is every vertigo patient, what's the frequency that it's going to be a stroke? Well, not everybody. Got some stats for you here, which, kind of surprised me. These only came out in the last couple of years, and I've been actually preaching this for, more than 10 years. So, acute, prolonged, but can be episodic vertigo. So, usually what we're looking for is someone who comes in, they've got ongoing dizziness, they're kind of hanging onto the gurney for dear life, because they feel like they're going to fall off. And they've got their eyes closed, and you can see their eyes twitching underneath the nystagmus, so they have an ongoing picture. That could be labyrinthitis, but that's the case, that's the group of patients we're looking for. Not someone who comes in and said, that I'm lightheaded, or I got up out of bed and, the room was spinning for a few minutes and then it stopped. That's not what we're looking for. We're looking for ongoing dizziness like that. Those patients should be subjected to a stroke code. 20% of strokes are in the posterior circulation, and dizziness or vertigo is the most common symptom in posterior circulation stroke. So this is something you're going to meet all the time. It's not a rarity. Isolated vertigo as a stroke presentation is not as rare as we previously thought. I think the reason, it's not just that big pica vessel that gets occluded to cause vertigo. There are all these small little vessels that serve blood flow to the brainstem that we're now discovering can cause only vertigo and no other stroke symptoms. And it can be even hard to detect on an MRI. So it's really kind of a struggle. So now that we're drilling down and finding this with more advanced imaging, or imaging again later, or understanding the exam and what is central and what is peripheral, what is inner ear, what is brain. On the exam, we're finding out that there are a number of other areas where you can have a stroke with this presentation. And previously, we would have treated them with meclizine and sent them out the door and never knew they had a stroke, never knew it. So that's why these stats have changed. Stroke is a diagnosis in only 3.2% of all ER dizziness cases. So I don't want codes called on every dizzy patient. Okay? But if you get down to what I call acute vestibular syndrome, that's what we're talking about right here, this picture, that patient on a gurney with ongoing vertigo, even just sitting there. If you get down to that, only 10 to 20% of all ER dizziness cases. So now we've got it skinny down to, a really small percentage of the dizziness cases in the emergency room. You call a code on those, about a quarter of the time, it's going to be a stroke. Okay? So do I want codes called on people with labyrinthitis? Heck yeah. Because, acute labyrinthitis picture is what we're talking about right here. About a quarter of the time, it's not acute labyrinthitis. And we should sort that out with the exam and then with imaging. Okay, so the differential, that case I was describing where, you know, someone elderly gets up out of bed and they spin for 10 or 20 seconds, and then it's done, and then they move their head, and then they spin again for 10, 20 seconds. That's benign positional vertigo, very mechanical problem in the inner ear that we can get a physical therapy person to help them with. That picture by history, we don't need to subject that to a stroke code. Just this acute vestibular syndrome. And if you've got that, the differential is it could be labyrinthitis, it could be a condition called Meniere's disease, where they have, you know, some electrolyte imbalance, we think, in the fluids within the inner ear, and it causes some, maybe some swelling of the inner ear mechanism, and they'll have kind of an acute to subacute onset of that same picture. And then this probably happens more often than we think, especially migraine can present with vertigo every once in a while. So these ones are hard for us to sort out. In fact, we just had a stroke mimic that we treated with TPA that we thought was a stroke, and it turned out to be a migraine with vertigo and some numbness. Stroke, very acute onset. So that's our differential. I have historical items that help to differentiate the things on that list, but I won't go over them in detail. I'm devoting kind of a lot of slides here to vertigo, but I do want to drive it home that it's probably something you haven't done before to call a code on some of these cases, and we really do, yep, we really do want you to do it. So history, we look for this history, whether or not, then we look closely whether or not there are any central signs to go along with it. So if someone comes in with vertigo, sometimes that can be kind of the overwhelming picture because they're so uncomfortable and vomiting and so forth with it. And we only later find out that they have numbness on the right side of the face. Well, then we move toward that's central. And then I have to sort out, is it migraine or is it stroke? But so you look whether or not there are any central focal symptoms, older age and other vascular risk factors. So let's say there are no other focal symptoms, but they're, you know, 65 like our other lady, and they're diabetic and, you know, have a lot of stroke symptoms. Then that 1 in 4, you know, of the acute vestibular syndrome maybe goes down to 1 in 2 or something. So we get a little bit more anxious, and we certainly want to do extra imaging. There's a HINTS exam that, you know, at some point it'd be nice to come back and do a lecture just on vertigo and talk about the differentiation of that in the ER. It's kind of a long talk, but there's a quick ER exam that we'll do with you over video in order to try to pigeonhole whether it's central or peripheral. And then imaging will help us, and if we can get MRI imaging, sometimes that can be helpful in discerning. Okay, so enough about vertigo. Any questions about that? A lot of stuff on my slides. So, okay. You wouldn't think we'd miss this one, but we do. How am I doing for time? Good. Okay. Good. So basilar artery thrombosis. You know the important basilar artery. Brainstem strokes are horrible. I'll just give you an example of a case to talk through how basilar artery thrombosis can present and how it can get missed. There was a 19-year-old, and I can tell you his story because he made it known when he was the American Stroke Association hero for Minnesota, and told his story and his recovery at meetings. So he's 19, and he was living in a dorm up at UMD in Duluth. And he one day came out of his frat house and collapsed on the steps. And he was getting up and, you know, was incoordinated, and speech was slurred, and they called 911 for him. Medics got there and looked at him and, you know, what would you think? You know, you're a 19-year-old at UMD. Yeah. And so that was the first thought. But he was clearly disabled. They put him in the vehicle and they started taking him in. And then all of a sudden his level of consciousness deteriorated and he started posturing in the rig. So what was happening? The clot was sitting here when he started, where it was getting both sides of the pons, and he was getting ataxic on both sides and having kind of fluctuating weakness, severely slurred speech oftentimes with brainstem events. And it was maybe subocclusive, so he was getting some flow around it. And then also you can get flow to the top of your basilar from your anterior circulation. You remember the circle of Willis, how it connects the front circulation to the back circulation. So you can be perfectly awake and having, you know, your basilar artery completely occluded or partially occluded. So that's the picture. He looked drunk. He looked drunk. And that I have more than one basilar artery thrombosis missed because that's what they thought it was. So then when it migrated up here, your level of consciousness centers are up there in the midbrain and upper pons. And so the little perforator arteries got occluded that go to that area, and he went into a coma. When you get, and both sides became paralyzed. And when you get sudden effect on the motor system in the brainstem, it doesn't always go flaccid. In fact, very often it becomes posturing, and it'll look like someone having a tonic-clonic seizure. And so that's the other area where we miss it. People come in with report that they were, you know, they had extensor posturing and they were in a coma, found out. They get, you know, Valium or Ativan and intubated, come in, get a CAT scan looks fine. You know, they give them anticonvulsants and they're wondering why they're not getting better. And hours elapse before they figure it. That's exactly what happened to him. So when he got in, CAT scan looked normal, and they intubated him, and then called a neurologist down there. The neurologist looked at the CT and said, "You have a clot sign in the basilar. You know, this guy's having a stroke." And so then they did the CTA, and sure enough, you know, you can't always see the clot sign, but it was evident on his CT scan. So they did give TPA, and he ended up coming down to us for mechanical thrombectomy after that. And he ended up doing some injury to his pons and looked pretty tough for a while, but young people, you know, have a easier recovery than people like myself. And so he actually had an excellent recovery, and I know reperfusion was part of that. If he hadn't been reperfused, he wouldn't have recovered. But he had a big hill decline because we were a little late to the game. So coma and posturing with upper basilar occlusion, fluctuating bilateral deficits in arms and legs, and dysarthria can occur with subocclusive basilar clot in the mid-basilar. And it can be mistaken for being drunk, you know, some other encephalopathy, that sort of thing. So whenever you see someone coming in with sudden onset of a neurological condition, you know, you should think stroke. In some of these large artery problems, I'm getting to the end of my list here, so some of these large artery problems, easily discernible with a CTA. So call a code, we do a CTA, and then we'll pop out of the stroke code as soon as we exclude it. But so this is where I get into talking about we're casting a wide net. You know, a good portion of the time, people coming in with posturing are going to be seizures. They're not going to be stroke. So here's the serious cases that we can miss in triage that don't look like a stroke at first. All those cases I shared with you. Here's the arteries that are occluded. Here's the things. Oops, something didn't register right. This should be over here, peripheral nerve. But this is what they end up imitating. I mean, I think you need to be judicious about it too. We're looking for those focal neurologic deficits with some of these things, so we, you know, don't call codes on every patient that's drunk. but you know what I mean. So just keep it in the top of your mind. Sudden onset, we don't have another explanation for it. Listen, question the confused patient for aphasia. Look to see if they have comprehension. Hold up 2 fingers in your right hand. You can do it really easily. Just look for other signs of delirium to take it in the other direction. If you think it's not stroke and it could be delirium. Check their visual fields as part of your standard. Painless leg weakness, think about stroke. Unresponsive awake, check the lower extremities for weakness and do a CTA to look for bilateral anterior cerebral artery occlusion.
Stroke code, ER.
Stroke code,
Stroke code, ER.
We can't take you all of it.
You can go, we're okay.
We'll
You
take
know
a
what?
break. You might as
You
well.
know what,
You guys
talk
come back and tell us.
You
Yeah,
talk
want me to
through
go
the
through the
stroke
process?
code, yeah.
Okay.
Do you know how to get there?
Somebody want to
Yeah.
take her?
Somebody
Yeah,
needs
she's
to
gonna
take
need
it.
a- she needs a transport.
This maybe isn't such a good recording, we might have to do it again.
Okay, I might be the only one that doesn't know this, but can you explain the difference between just a CT and a CTA? Like, I don't know what that means.
So what the CT, so if we say CT without contrast, that's basically looking at the brain, and what that does is it looks for hemorrhage, is what we're looking for.
But with the CTA.
So CTA is looking at the actual vessels. So when we say the large vessel occlusions, that's what we're referring to as the results of the CTA, and looking at whether or not, so with CTA, if you inject contrast dye, you can see where all the vessels are. And if we see a cutoff and we don't see a vessel, that means that there's a thrombus there. So if we hear the terms cutoff or anything like that.
one's dye,
One's dye.
Yep, one's dye and looking at the vessels, and one is actually looking at the brain tissue. And if we say that they have a negative CT, everyone's like, oh, that's good. Well, that's good that we can treat, because that means that there's no hemorrhage there. So that's really what we're looking for, is we rule out hemorrhage. We're not looking to see a stroke, because if they are having a stroke, unless it's in an extended window, we're not gonna see that on CT.
So is there ever a reason in these situations that you wouldn't just go and just do both?
So sometimes the neurologist, if you get them on board right away and they know that they're in the extended window, they might recommend that the CT-CTA is both done, just because they know that they're outside of that treatment window. But the standard, what we really preach, and I'll kind of go into it a little bit more, I'm kind of getting ahead of myself here, is we're ruling out that hemorrhage right away so we can treat with TPA. And then we want to treat as soon as possible, because we have a shorter time frame that we can treat with IV alteplase. We have a longer time frame that we can go in and intervene with intervention. So then that's why we go back for CTA.
So how long does a CTA take?
CTA.
Like in comparison, like the CT is so fast.
Yep.
Now.
So CTA, sometimes it can take a little bit longer, just because you have to have a large board and a cubital IV. And then you have to inject contrast dye, so sometimes it can take a little bit longer. And some of our more rural sites take a little bit longer, aren't used to doing CTA as often as just non-contrast head CT. So that's why we really kind of preach the CT without contrast first.
Can you put a mic on?
Oh, am I really soft?
Yeah.
Usually I get told I talk really loud.
Put it way up on your scarf. Put it way up
Oh,
on your scarf.
way up on my scarf. Okay, can you hear me now? Do a mic check.
She might have turned it off, I think. Much better noise.
It's good? Okay, tell me if you can't hear me. So I'll kind of back up a little bit, and I'll kind of explain a little bit of the imaging piece as we go through the stroke code process. So just kind of to outline some of our program goals. So as Sandy said, time is brain. 1 minute of an untreated stroke equals a loss of 1.9 million neurons. So even though we have up to 4.5 hours to treat by alteplase, even though we have that window for IR, we want to be treating as soon as possible so we can decrease that deficit caused. So our program goals for United are pretty aggressive, so don't be scared by these, because we do meet these at our Telestroke sites, believe it or not, and at United. So door to stroke code activation, so that's going to be when you assess that patient or get that pre-alert and you can determine that the patient's having a possible stroke, and you're doing that overhead stroke code activation. Door to United patient placement, this is going to be another step that you're going to have to get used to when you're activating that stroke code. So we have a number that you call. Our United patient placement is kind of like our one call system, and they will page the neurologist. From there, the neurologist has 10 minutes once they receive the page to give you a call back, ask what's going on, and then they'll determine whether or not there's a need to connect on video and run that stroke code over video. If it's a non-urgent case or what have you, the neurologist might not connect at that time, make recommendations in the ER, and then do that inpatient consult. Door to CT scan, we want to have that patient, once they hit the door, we want them to go to CT as soon as possible, and then immediately from CT, bring them back into the room, and you can place additional lines. You can do your chest x-rays, your EKGs at that time, but we really want to get that patient in front of the Telestroke camera, so that way the neurologist can start getting that history, assessing that patient. They will do a few exam items. They might not do a full NIH at that time and determine that that patient is having a stroke, order IV alteplase, and then finish with their exam and do the full NIH. So they're going to do a pretty quick assessment, lay eyes on that patient, and really determine that treatment criteria and if it is indeed a stroke. Door to needle or IV alteplase within 30 minutes, and really what makes or breaks this time is those pre-alerts from EMS. So calling the stroke code right away when you get those pre-alerts, calling United Patient Placement, even if the patient isn't there, maybe they're 5 minutes out, just let that neurologist know when they call back that you got that pre-alert, this patient is coming. If you have that patient information, they can be looking in the EMR even prior to that patient coming. So there are a few things that they can be doing even before that patient arrives. And it just gives them a heads up. They might have multiple codes going on with our sites at a time, so that way they can kind of be like, okay, I know the patient isn't there, but I know I've got to call Lake Region back as soon as possible. Door to puncture, if it's an in-house code or not an outside transfer, we want them from door to groin puncture time for mechanical thrombectomy within 90 minutes. If it were to be a patient that's coming from an outside site, we do give them a little bit longer, 120 minutes. So Telestroke. So what exactly is Telestroke when we're talking about it? We pretty much have a similar cart set up for you here at Lake Region, but it's a 24-hour, 365-day coverage for a stroke alert. So as Sandy said, we don't want to just be a consult service. We want to really try to integrate ourselves into your ED and part of that stroke code process. So basically it allows you to have access to that stroke neurologist via Telestroke, so they can view that patient and examine them just as if the same as if you were in the room with your assistant. So we don't expect you to be an expert in all of the exam elements, but just helping to facilitate that exam with the neurologist. So basically collaboration with you as well as the United Hospital Stroke Service, and bring that high level of IV thrombolytic intervention. Like we said, we don't want you to be determining the treatment criteria. That's why we've got the stroke neurologist there. So do that stroke code activation and they can help with that decision making. So the various activations of the stroke code process, so this can be by EMS service, a walk-in to the emergency department, or an inpatient stroke code. So what kind of a team effort does it take? Really with stroke versus something like a STEMI, there's a lot more people involved, there's a lot more steps to the process, there's imaging, there's assessment, there's a lot more to it than just kind of reading that EKG, so it's really a team approach. So EMS activation, so patients that arrive with EMS that have that pre-alert, we want those patients to go directly to CT scan as soon as possible. So if you have to do a quick pit stop, lay eyes on that patient, and then bring them straight to CT scan, they can stay on that EMS stretcher while you transfer them there. Those patients that are not a pre-alert, they can be transferred to the ED bed for that assessment and then activate that stroke code at that time. The stroke code is activated upon the direction of a nurse or physician who's identified that patient meeting that stroke code criteria. From there, the nurse or designee can activate that overhead stroke code page. So this can be the nurse, unit clerk, ED tech, or health supervisor that's going to activate the overhead call by activating the stroke code button on the call light system, and then that switchboard is going to announce the stroke code activation. And then the department director, house supervisor, or clinical coordinator, one of these three designated people will call our United Patient Placement. And that number is listed here. You will get to the point where you have it memorized. So just remember, stroke code activation, call United Patient Placement. We really preach that we want this done simultaneously. Where we see delays is where you're calling that in-house stroke code, but then you're not calling patient placement right away. And that needs to happen to get that neurologist on board as soon as possible. House supervisor will assist with calling in additional staff if it's after hours. Even if you don't have all of the patient information available for patient placement, with that EMS pre-alert, so go ahead and call them, just let them know that you're working on that, on obtaining that information. Ambulatory arrival, see, this is going to be patients that walk into the ER. Again, that assessment is done by that nurse and physician, and they will determine whether that patient meets that stroke code criteria. And then the designee will overhead stroke code page. Department director, house supervisor, clinical coordinator will call United Patient Placement, and then the house soup also assists with calling in staff. Inpatient activation is a little bit different. So again, still being activated by that nurse or physician who's identified that patient as meeting a stroke code criteria. Really what we see for a lot of inpatient stroke codes are the hardest stroke codes. And that's anywhere and everywhere in every facility, especially post-procedure. You kind of think maybe it's anesthesia. We see that quite a bit. Don't be scared to call stroke code if your gut's telling you something's really off. The primary nurse or designee, unit clerk, charge nurse, or house supervisor is going to activate that overhead stroke code page. Department director, house soup, or clinical coordinator is going to call United Patient Placement and really try to obtain that time last known well. We really preach clock time versus half an hour ago. Half an hour ago, each time you give that report of half an hour ago, lengthens that half an hour ago. So that's why we really want to have that clock time if you're able to get that description of the deficit, get that stat blood glucose, obtain those vital signs, keep SpO2 greater than 94%, if possible to have an estimated or actual weight. It doesn't have to be an exact weight if you can get an estimate or if you have one documented previously in the record. And reason for admission, history, if they've had recent surgery, are they on anticoagulants? And then that patient will be transferred immediately to the CT scanner, and then from there that patient is going to stay in the ED. So it's quicker to go from CT to an ER room with that telestroke camera versus going back up. If additional imaging is needed, going back down. So really bring that patient to CT and then having that patient stay in the ED for the remainder of the code. And the hospitalist primary nurse and code coverage nurse are going to accompany that patient to the ED. The hospitalist will assist with entering those orders, including the IV alteplase order set. Pharmacy, when they are in-house, will be mixing IV alteplase. If it's after hours, it's going to be the ED nurse. So we don't expect inpatient nurses to be mixing drugs. And if the patient originates anywhere elsewhere outside of the ICU, the care of that patient is going to be transferred to the code coverage nurse. So as we kind of go through the role breakdown, you'll kind of see why the code coverage nurse kind of takes the bulk of that role, including conducting the telestroke exam. The primary nurse can help with providing that history as they've been the ones caring for that patient. And then the code coverage nurse will be assisting with mixing drug if after hours, perform that dual nurse sign-off, document post-IV alteplase vital signs and neuro checks, transfer that patient to IR suite if they meet criteria for mechanical thrombectomy, or assist with transfer to outside facility. If that patient originates outpatient or in the clinic, call the Lake Region Emergency Department or transfer directly to the ED if they're in the clinic. So we'll go over some of the individual roles for the stroke team process. So again, several pieces to the pie, so it really is a team approach. So for EMS, we can't stress enough for them to be calling those pre-alerts, to be helping with that door-to-drug of 30 minutes and transferring that patient directly to CT scan. We really want them to be knowing that clock time as well for time last known well. Name, date of birth if they're able to obtain that description of the deficit, vital signs, blood glucose, IV status, trying to have at least one IV placed prior to CT and IV alteplase. Second IV isn't necessary before you start IV alteplase. Any interventions done en route, name and phone numbers of witnesses, patients, family, or friends, medical and medication history.
You said the second one is not necessary.
The second one is not necessary unless you're having issues controlling that blood pressure, then we're gonna want at least 2 lines. So if you're having issues controlling blood pressure prior, it's best to place that second line because we're probably gonna need one for alteplase, one for a nicardipine drip. Otherwise, we don't wanna delay inserting all kinds of lines prior to CT scan. So really, we've kind of moved away from placing Foley's prior to alteplase or any of those things, as long as it's a compressible site. And really, a Foley isn't something that's required for treatment either. We don't put Foley's in all of our alteplase cases.
So our protocol probably is changing too.
Yep,
then.
yep.
I know that was all in the protocol.
Yeah, so the protocol has been updated, and I know there are some stroke findings in the ED as well as upstairs on the unit, if you want to take a look and review the protocol. So it has been updated to reflect that. So we don't want to delay alteplase for placing that Foley. So some of those things we've really kind of gone away from because we're just really aggressive with wanting to treat that patient and wanting to treat as soon as possible. We obviously want to be safe. We still do require a dual nurse sign-off, want to be doing those double checks, but some of those additional line placements we can hold off on. So the unit clerk or ED tech is going to be the one activating the overhead page as directed by the primary nurse, and the switchboard will be announcing the stroke code, location, and room number. They will activate the stroke code orders, initiate arrangements for transfer as indicated, and we do have a fax face sheet that we'll keep in the ED as well as the inpatient, so you can just fax that patient's face sheet to the United Clinic and patient placement. Switchboard operator, they're going to receive that notification from the call light system and announce that stroke code overhead, whether it's ED or inpatient. And the house supervisor, they can also activate the stroke code by hitting the button on the call light system. And then also calling United Patient Placement to request to connect to the Alina Telestroke neurologist for a stroke code activation. When you're calling United Patient Placement, again, request to connect with the Alina Telestroke neurologist for a stroke code. State your site name, Lake Region Healthcare, Fergus Falls, location of the patient if you're in the ED or inpatient, patient first and last name as well as date of birth, primary physician, so whether it's going to be the hospitalist or that ED doc, and direct callback number. If it is a patient that originates inpatient and you're calling United Patient Placement and you're transferring down to the ED, it's probably best to give the ED number for the neurologist to call back, so that way they're not calling the unit and then they're like, oh, the patient went to the ED, and then they're calling the ED, so kind of delaying some of those times of getting a hold of the correct nurse or physician to talk to. Provide additional or call in additional staff as needed if it's after hours, and provide support to necessary areas, including coordination of the stroke code and assisting with bed placement. So department director or clinical coordinator, again, if not already done, by previous designee, calling United Patient Placement and providing support for the stroke code process and admission to the ICU. The ED physician or hospitalist will be part of that triage process and activating the stroke code if not already done by nursing, making sure that patient is transferred directly to CT scan, overseeing at least one anticubital IV is started right away and prior before the patient leaves to CT scan. However, we don't want that to delay transfer to CT. Obtaining that history and criteria for treatment, initiating the stroke code order set, and the order sets we have been currently updating them here, so that way they are updated with the Telestroke orders, all of the imaging labs, and everything necessary for the stroke code process. Reviewing the case with the Alina Telestroke neurologist via phone call, and then, like I said, that neurologist will determine whether or not there's a need to connect over video. Prior to treatment, systolic blood pressure has to be less than 185 and diastolic less than 110. So we need to be aggressively treating those blood pressures. Even before or during you're getting that patient to see CT scan, bring that dose a little bit, a lot of CT, trying to be getting those blood pressures down as soon as possible. Perform the NIH stroke scale. Like I said, prior to CT scan, you might not be getting all of that assessment piece done. You can be doing part of that assessment even as you're carting that patient. You can be asking them those orientation questions, holding up 2 fingers. So you can be doing part of that assessment even as you're transferring the patient. Discuss the treatment decision with the Telestroke neurologist after CT scan, and then entering the order for IV alteplase. After the initiation of IV alteplase, the patient will go back for CTA, unless, like we said before, if they're really in the extended window, that might be the time that the neurologist is going to recommend a CT-CTA to be done. And then the ED physician or the hospitalist will be the ones to actually place the orders. The neurologist is only going to provide their recommendations, but it's up to the physicians here to be placing the actual orders in the EMR. After CTA, they'll discuss the results with the interventional radiologist and determine whether the patient needs to transfer to IR here or if they need to transfer elsewhere for intervention. The Allina Telestroke neurologist will receive the notification from patient placement and will call this